Hi, this is Dr. Janson, and today I'd like to go over a case study of a patient with 3 rather rare problems. And I'm hoping that if there were another practitioner out there who saw one of these problems, or a patient, that this video could help you find a solution to the problem. So the 3 problems that the patient had are complex regional pain syndrome, which is quite rare. It's in arms and legs, and of course in feet. I see it in feet. The patient also had a torn plantar fascia, but near the ball of the foot. So a distal or far away tear of the plantar fascia, which is rare. Usually if it's going to tear near the heel bone and cause heel pain. So that's rather rare. And then the third thing that the patient has is a plantar plate dysfunction, and that's under the ball of the foot, a little cartilaginous piece that's not healthy right now. So those are the 3 problems the one patient has basically. We'll call him Joe. So Joe came to me a couple of years back, and he had for 7 years, he had had terrible chronic pain in his right foot, and it had started when he was 29 years old, playing ping pong after a business meeting in a hotel. They had all gone to the game room and were having a lot of fun playing ping pong, but were wearing dressy, thin-soled leather shoes, so they didn't really have the right shoes for that. And they were having so much fun, they were playing for hours. And then the next day, or 2 days later or so, poor Joe's foot was killing him, and he went to many doctors. He had many procedures. He had surgery, cortisone injections, sclerosis treatments. He had a neuroma removed, the nerve removed near the ball of the foot. So he had many procedures, many pairs of orthotics, custom-made orthotics, and nothing helped him. And then after a while, he developed a discolored foot. And when the nerves are communicating, because there's an unhealed injury, after a while, they'll sort of go crazy and start innervating everything. So what happened with complex regional pain syndrome is that eventually you'll start to have not just the pain signal nerves working, you'll also have the sympathetic nerves working as well, and those control your circulation. So the foot will swell, it'll turn colors. It's usually red, but it sometimes can be blue as well. So when I met Joe, 7 years after his original injury, so he's 36, I believe, when I met him, the bottom of his foot looked like chopped meat. It was a very irregular shape. It wasn't smooth skin. It was, very like, undulating skin. And it was very deep red, terribly unnatural color. So the foot was just in really bad shape. Now, it's my experience that you cannot get rid of complex regional pain syndrome unless you treat the original injury. So now Joe had many MRIs and x-rays. He had ultrasound imaging. He'd had a lot of tests done, but I don't think he was clear on the diagnosis. And the way I diagnosed it was with a simple, old-fashioned clinical exam. Now, I've been in practice for over 35 years, so I have, the benefit of a lot of experience looking at feet, and I see distal tears in the plantar fascia once or twice a year, which is a lot, but I have a strange practice where I make handmade orthotics, so I'll get a patient like this who's seen many doctors, and then finally they'll find me. So I see it rather regularly, like every 6 months or every 8-10 months I'll see one. So I've seen it a lot. I've seen 40-50 patients with this problem, say. Now I'll show you how I diagnosed it. So the plantar fascia is a ligament that goes from your heel bone to the ball of your foot. So what I did with Joe was I just simply was moving his toes, and I don't know if you can see the band here. This is the plantar fascia on my foot. So it's kind of easy to see the plantar fascia. So when I was bending Joe's toes, I noticed that I didn't see any movement in the plantar fascia. So that was a clue that there was a tear between the body of the plantar fascia and the ball of the foot. And now I'm no artist, so I drew this little sort of a cartoon drawing so that I could explain it to you. So this is the skeleton of the foot. Here I have a foot here, so you know this is what the skeleton looks like. And I put him in an orthotic because he's missing his soft tissue. So anyways, but this is the bones. And then this is the ligament that I was telling you about, which attaches to from the heel bone to the ball of the foot. So this is the toes, you see. And this is the plantar plate that I was telling you about. So this is a fibrous cartilaginous tissue that's part of the plantar fascia, and it goes underneath the metatarsal bone here. And you can see how it makes a nice ball and cup kind of situation. So the plantar plate acts like a cup. And then when the foot is moving, you know, when you're toeing off, you're walking, the metatarsal head, which is round, you see, that can fit right into the cup. And then it rotates in the plantar plate like that. So when I was moving Joe's toe, I didn't see this moving at all. So I drew this like cartoon-like drawing of what Joe's plantar fascia looked like. So it was torn just before the plantar plate, like this. So when I moved the toe, this part of the plantar fascia didn't move at all. So that's how I knew that there was a tear there. And he had an MRI that actually confirmed that, but some of the MRIs were not clear and sort of muddied the water as far as the diagnosis goes. So Joe did go to doctors who really weren't clear on what the problem was. So I made Joe a pair of orthotics first of all, and what I wanted to do was to bring the plantar fascia, you know, back together again so that it could heal. So I needed to bring the ball of the foot close to the heel of the foot, and the way I did that was I made this orthotic. So this is his old orthotic from 2 years ago, from a couple of years ago, and I made this very large toe crest here on the orthotic. Now he wore this for a while, so it was even higher before. It's compressed a bit, so it's lower than it used to be. But the idea of that is to heal a distal tear in the plantar fascia. The idea is that if you could raise the toes with the toe crest, that you would then decrease the distance from the heel bone in my right hand to the ball of the foot in my left hand. You see? So you're going from this to this. So the plantar fascia is shorter, and then the tear would come together. So that's the purpose of using a toe crest to heal a distal tear. And remember that I also said that in my experience, and I've treated a lot of complex regional pain syndrome, it is not possible to get rid of it without healing the original injury that caused it in the first place. So we had to begin with Joe. We had to begin by first healing that plantar fascia. We had to bring that back together, and that's why I made that bizarre orthotic. And it wasn't really particularly comfortable. And then over months, and it took 8 months. So I met him in September of a couple of years ago. And then in May of the next year, that's when I noted, when I moved the toe, I could finally see movement of the plantar fascia. And it came in slowly by slowly. Now, to treat the complex regional pain syndrome, I also did a series of STIM treatments, or TENS, which is transcutaneous electrical nerve stimulation. It's an acronym, TENS, TENS. I used a TENS unit. I gave him 12 treatments with reverse polarity. That's how I treated him. And I also did a laser treatment on him, which, and what the laser does is it makes the blood vessels dilate, so more circulation would help, heal that poor injured tissue. So, and luckily his foot was much better in May. And then we could deal with the last problem, which is plantar plate dysfunction. And now I drew another cartoon drawing so you can see what that's all about. So this is the drawing I drew of Joe healed up in the May. So when I moved the toe, I did see movement of the plantar fascia, so I knew that it had healed up. But this part of his foot was very uncomfortable. So I drew this picture to represent that the plantar plate was not matching in location with the position of the metatarsal head. And that probably was because this was attached, going back to the injury, the portion by the toe was attached, but not attached behind it here. So this probably shortened up and put the plantar plate in the wrong position. So how do we treat this now? So what I need to do with the next orthotic has a very different purpose from the first orthotic. The purpose of the second orthotic will be to lift the metatarsal head. So basically, instead of having the toes up, we actually now want to bring the toes downward. And what that will do was change, this position. This is where the metatarsal head was, and then we, with the new orthotic, we push up on the metatarsal, and then it will fit back into the plate. You understand? So instead of it being the metatarsal being like this, we're going to lift the metatarsal up so that it will match with the cup. So we're going from this, inclination of the metatarsal to a less inclined metatarsal, so it'll fit better in the cup. So this was the original orthotic, and this is rather flat here, but this is high. So the new orthotic will be the opposite. This is very low here, and I realize it's black, it's hard to see it, but this is low where this is high, and this is high where this is low. It's flatter here, and this is like a ski slope. Wah! See? So, and the reason why I'm doing that is because this will bring the metatarsal, so from this to this. So I'm raising the metatarsal here like that. Okay, I had to think myself. Here's his cast, and the way I did it was I carved the plaster out here. You see I carved this all away. This is the old cast, so I carved it here just to show you. I have another cast, it's a new one. This is the old cast, and I just carved it just to show you how I did it. So I carved all this plaster away here. And what that does is now I have this metatarsal dome or a rise in the metatarsals here like this, and that pushes the metatarsal up. So that's how I'm going to fix the plantar plate problem. Now the other part of it is the shoes are going to be really important now. So remember I told you that I wanted Joe's toes to come up, right? With this. So his toes have to come up. So we needed a shoe that was very flexible like this, see? Because his toes come up. And that's how I got that plantar fascia to come back together. But now we actually want the exact opposite of that. We want to have a shoe that has a stiffer sole. So this was an old shoe that Joe had. He gave me this one. So this one is better because it's harder to push it. You see, I'm pushing pretty hard there. I can't really bend that shoe. This one I can bend real easily. This one's harder to bend. But I'm actually having him get a new shoe. I'm going to have him get a Hoka Bondi 11. That's the brand in the model. Hoka is the brand. And Bondi 11. And also an extra wide. Because another interesting thing that happened is that, and you can see with the new orthotic on the old cast, you see how his foot got wider. His right foot got wider there. I don't know if you can see that. There's about almost like, I would say 3/4 of a centimeter. So his foot got wider. Just his right foot. His left foot stays the same. And that's because he had his neuroma removed. And it's kind of a side effect of getting a neuroma out. The foot will, over the years, become wider. So you will need wider shoes. So he needs to get the extra wide version of the shoe. And then we'll work on that for probably, I'm going to guess, around 6 months. Until his plantar plate is, fitting better on the metatarsal head so it can heal up. Now, another thing that you could do for dysfunctional plantar plate is do biological injections, which will heal up the rate of healing. There's basically two kinds. One that comes from your own body, that's called PRP, it's platelets. And then there's amnio injections, which are from a donor donating tissue that's spun down to get the nutrients and molecules that help healing. Both work really well. I would say PRP works about 50% of the time, and the other one works 75% of the time. The only problem with them is that they're very expensive. You need at least 3 injections, 4 or 5 injections. And each injection can cost $1,500, $2,000, so you can see it's very pricey. So, but it would help speed up the healing, and like I said, even alone, they do have a pretty good rate of healing by themselves, 50%. So of course we would, with Joe, we would use, certainly the orthotic will put him in a good position, the right shoes, and then maybe he would consider getting biological injections just to speed up the rate of healing at this point. So that's the case study today. So it's 3 very kind of rare problems, which is complex regional pain syndrome. If you look it up, it says it's incurable. It is curable, but you have to heal the original injury. That's the only way to heal it. And then use, I do recommend TENS unit is another part of the treatment. And then he had a tear in the distal plantar fascia, which is rather rare. And the way I treated that was with the toe crest on the orthotic, and also a flexible shoe, a very flexible shoe and a toe crest. And then the last problem is the dysfunctional flexor plate, and that's what we're working on now after we've healed up the original 2 problems. And that is the opposite shoe. You need a stiff shoe, extra wide, and then an orthotic with a something to elevate the metatarsal so that you can put the metatarsal back into the flexor plate, and then it can, being in a better position, it will function better. And then you might do biological injections to help the plate heal. So that's the presentation of the problem. I hope it helps somebody. I know these are 3 very difficult things to treat. And feel free to contact me if you're a professional. You can call my office. You can look, my name is Janson. You can contact me, and I would be very happy to help you find a solution. I see these problems. They're very rare, but I see them frequently. All right, thank you very much for watching.